Thanks very much, Sham. That was a really broad explanation of a comprehensive response. Thank you very much. There is a question that's come, but I'm going to hold it for the panel discussion because it's one that I think we need to bounce around all of the pharmacists. So we're going to move on then to Mazisam Wabunwa. Mazisam is president of the Pharmaceutical Society of Nigeria, and he will bring us a West African perspective on pharmacists as gatekeepers in a case study. Thanks, Mazisam.
Thank you very much, Andy. I want to start with congratulating the Global Self-Care Foundation for this program, because I think it's a very important thing for us to do. Self-care is on the increase, whether we like it or not. And therefore, it's important that we do something to try and drive it towards the responsible self-care, utilization. You can't stop it. I know there's reluctance of physicians and sometimes some other healthcare professionals to see how they can limit it. All we can do is channel it to a more responsible pattern. The internet is driving people to become their own doctors and their own pharmacists and their own healthcare professionals. We can't give up on that. All we need to do is to rein and create opportunities to help them to get the benefit of healthcare or self-care and not to destroy themselves. So this is just my word to say that I think this is a wonderful program and I'm glad to be here. Can we then move on, please? Move on with the slides quickly. Move on. Yeah, it's important. Just the point I made is that self-care is inescapable. And why? It is estimated that by 2030, the world would have had a shortage of about 18 million health workers. 400 million people worldwide lack access to most essential health services. And 130 million
aux services de santé essentiels et 130 millions de personnes.
About 100 million people become poor, especially in our part of the world because of out-of-pocket healthcare costs. And disease outbreaks are becoming a constant global threat, as evidenced by the current pandemic. These are the factors pushing people to seek other ways if they can't have the appropriate healthcare personnel to take care of themselves, or the health facilities or the health structures are not available in their areas. They have to find a way, because even before we started the orthodox medicine, our Africans had a way of taking care of their illnesses before we introduced medicine in the form we have, even pharmacy. So that is still residual in our environment, and those are the kind of things we need to look at. Move on, please. The advent of the COVID-19 has put more focus on this, because in Nigeria, for example, I'm sure it's so in most parts of the world, at the climax of the pandemic, most hospitals were closed to non-COVID-19 patients. It was very traumatic for many people. Anybody that went to the hospital was either a COVID patient or afraid to become one. And when the disease was not well understood at the beginning, we thought it was as contagious as Ebola. And so people were like, resisting going to the hospital. But it was found that during this period, patients could not visit their doctors. And so they had to figure out how to manage their conditions with little or no support, especially when we were asked to stay at home, 24-hour stay at home. But patients who in time past had been more involved in the management of their condition, that is who have had some introduction to self-care, appear to be able to cope more with the new normal than those who are dependent on hospitals, health institutions for their medication. So there's always an advantage in everything. Well, I don't want to bother us. Move on, please. Self-care has been well, move on, sir. Next slide. Self-care has been well explained by a previous speaker, and so I shouldn't waste your time. Let's move on. The other thing is the benefits, which I believe are obvious. Two, it may provide more opportunities for individuals to make informed decisions regarding their health and health care. The concept that everybody's health is his own primary responsibility is also the thing that we need to continue to focus on as healthcare professionals. So often people seem to franchise their healthcare to healthcare professionals. I don't think that's the right attitude. Every individual has a right for, and primary right for his own health and well-being. Healthcare professionals are to help them, support them to achieve that goal. I think that's something, because in some climes, in some jurisdictions, people are so just cannot do anything for themselves until it is prescribed or it is recommended by somebody else. It could play an important role in improving health-related outcomes, especially in compromised health infrastructure and medical services that are prevalent in Africa, especially in our region. It helps to build upon existing movements, such as task sharing, which are powerful strategies to support health systems, because this is the way to go. And the physician who spoke made allusion to this. This task sharing had to be supported through a proper communication and understanding that the focus is on the patient. The focus is not on us, healthcare professionals. It's not on tough, asking for whose job is it to do and whose job is not to do. There is a collaboration to be able to offer the patient the best outcome of every medical or healthcare intervention. It's clinically proven to reduce heart diseases, stroke, and cancer, because these are non-communicable diseases that are chronic. And if people cannot be able to maintain self-care, they probably will never get sufficient professional care for managing these long-term and lifelong illnesses, and also been proven to improve mental and spiritual health. Move on, please. Move on, please. Next slide. Well, I think this is what we have been trying to describe in different forms by previous speakers. The patient is at the middle of all the interactions and all the interventions. And that's the critical thing. And these are activities which he is supposed to be part in taking. He takes part in all this, with guidance and education. He's involved in some level of self-testing, responsible self-medication, self-examination and monitoring, self-recognition of symptoms, self-administration of some medications, right nutrition, and health life choices. These are all part of the components of healthcare, and the patient must be properly guided in ensuring that he's at the center of all this, and he has the responsibility to do some of these things as appropriately informed and educated to do the right things at the right time. I think the focus is getting them to know how to be responsible in all this. And that's the role of the pharmacist comes in. Next slide, please. The role of the pharmacist comes in, as also have been made reference to, an important component of pharmaceutical care is to assist patients with self-care. This role is an element of the practice standards of several professional pharmacy organizations. Pharmacists, as we know, are most readily accessible to patients, and many establish long-term relationships with their patients. So they have trust and respect. And this trust and respect puts the pharmacists in the position to empower patients and help them make sound decisions about self-care. Of all the health professionals, except patients who are already hospitalized, perhaps many spend the highest number of time with a pharmacist in the chain of all the healthcare professionals. Those ambulatory patients spend the highest number of time and perhaps make more visits. So the focus remains responsible self-medication. Next slide, especially in countries like Nigeria. The Nigerian healthcare system is affected by a number of factors, two of which are: one, paying for healthcare out of pocket. That's one. And waiting long hours to see a physician in public facilities. I told one doctor when we were discussing one patient, I said, if every patient who had headache or malaria and waited to see a patient, half of them would be dead. To see a doctor before taking a malaria patient, given the endemicity in our country. So these factors of paying at very low health insurance coverage and waiting long hours to see physicians cause a big reliance on other sources for treatment, as I made reference to, such as traditional healers. They purchase medicines from patent medicine vendors or pharmacies. So self-medication is a common form of treatment. It's inescapable. It's an inalienable right of the human being, of the patient. So our job as pharmacists and as healthcare professionals continues to be, how do we guide them to ensure that in exercising this fundamental human right, they do it in a manner that they'll get the best outcome instead of having to complicate their matters. Move on to the next slide, please. Next one. Now, self-recognition of symptoms. The pharmacist's role is evolving to be more patient-focused, especially those at the community level. During the pandemic and the lockdown, as I said, most patients were not able to visit hospitals for treatment, and so had to rely on their pharmacies for medical help. In cases of certain chronic conditions, a collaborative model is what will benefit the patient in self-care. Here, of course, the first person is first diagnosed by a physician who provides the initial treatment plan. Then the pharmacist educates the patient on identifying signs and symptoms of recurrence and ways to effectively self-treat these recurrences, as well as identifying circumstances where it is necessary to consult their physician. They also advise the patients on potential adverse events associated with their treatment. Again, this is where sometimes the conflict comes. We always insist, and I think most pharmacists will insist, that patients get prescriptions for see their doctors first before initiating medication, especially for chronic illnesses or even very serious acute illnesses. Then before the pharmacist dispenses the medication and can then educate the patient. And when it gets to the point where the patient needs to see his physician, the pharmacist refers him back. I think this is always the point of inflection, that the pharmacist must know at what point to refer the patient back to the physician. And this is the point we need to get well so that we have better cooperation from physicians, so that they do not think we are promoting irresponsible self-medication. Let's move on. Medication adherence. Community pharmacists in Nigeria. Next slide, please. Community pharmacists in Nigeria play a vital role in educating patients about treatment benefits, administration techniques, dosage flexibility, and managing side effects. This increases the likelihood of medication adherence. By virtue of training, pharmacists are appropriately positioned to assess patients who are not compliant with their medication and can, in collaboration with the patient, develop effective methods that will promote adherence. This is why communication is important. Writing take 1 3 times a day, take 2 6 hours a day, do not or does not guarantee that they are taking. But by proper review of how the patient is taking the medication, the pharmacist can guide this patient to take their medication. So very often, especially in our environment where people may not be as literate as everybody else, but when you tell them to do things in English, you may need to come down and speak in their local language so that they can really understand. But sometimes they won't tell you they didn't understand out of self-pride or trying to maintain their dignity. Self-monitoring, next slide. Frequent visits to hospital or clinics to monitor their condition can be burden for patients. I think we know that. If patients are able to monitor their conditions, they are more likely to better manage their conditions. Pharmacists do help patients to shift from relying on hospital clinic visits for monitoring to at-home monitoring by educating them on how to use self-care devices, just as the glucometer equipment, the blood pressure monitors, and peak flow meters, and also provide information on how to interpret the results and act upon the results. This is a green area because in most homes now, you have this equipment, this test yourself, measure yourself, and it's being promoted online and offline. And it puts responsibility on pharmacies, some of who sell this equipment as well, to continue to play a role in getting patients and their customers and clients to understand how this equipment are used and how frequently they need to be recalibrated, because soon they go off balance and off standard. And that is an area I think pharmacists need to do a lot in letting them know that this equipment needs to be recalibrated from time to time. Next slide. Healthy life choices. Another area where pharmacists' role has evolved in Nigeria is in helping patients select healthier behaviors. In the past, patients rely solely on their physicians for advice on their health lifestyle. But now patients understand that the pharmacists are members of the healthcare team and are able to advise them on health plans and even help them to develop an action plan for healthy behaviors. So some pharmacists are even carrying some of this exercise equipment in their pharmacies and beginning to play a role in advising and supporting the patient to maintain total quality wellness, given their lifestyle, especially those that have chronic illnesses that need to be advised on their weight and the level of exercise they need to do. Secondly, pharmacists in public health are also involved. Next slide, please. In our environment, next slide, please. We are finding pharmacists involved in playing key role in highlighting health issues through campaigns and public speaking. You know, campaign against drug abuse, campaign against drug misuse, and drug addiction, etc. We're doing campaigns on HIV testing, going to test TB, especially in those areas where the services are free. So these public health campaigns empower the public to get more involved in their healthcare management, because those campaigns give information to the patient and enable him take care of he or her health without waiting to get sick or without going to a health institution. Finally, take-home points. There's need for healthcare policymakers to support, I think, and involve pharmacists in promoting self-care interventions, because it is inescapable. Self-care is inescapable. It's an inalienable right. And if we mean well for the patient, our drive will be how to make this to be a responsible self-care and guide them appropriately. Improving self-care requires collaboration between healthcare providers and the patients. I think it was well made by the physician that spoke. Sometimes the misunderstanding is lack of communication, and knowing that there is adequate work for each healthcare professional to play in the chain of helping the patient to get the best out of his health management interventions. So collaboration is critical. Pharmacists should receive adequate instructions on self-care counseling during their pharmacy training. This is an area that is not as it ought to be right now. So we're recommending that to the Pharmacists Council and the universities to be sure that self-care is become part of their curriculum. And also we are in constant discussion with our members of our physicians, the Nigerian Medical Association, and other healthcare professionals on ensuring that both the job task shifting and different roles we need to play to support the patient, look after himself appropriately, is not misunderstood, but well choreographed so that we remove areas of friction. Lastly, patients should receive adequate instructions, as I said, and I recommend that that becomes something that every jurisdiction should include in their training or part of the internship program. Conclusion. Our experience is that self-care interventions offer a solution to improving health and well-being. These interventions can be significantly improved by engaging pharmacists who are very close and related to their patients. Engaging pharmacists can lead to reduced healthcare costs and improved healthcare outcomes. Once again, thank you for the privilege to participate in this wonderful and important seminar. Thank you.
Thanks very much, Mazi-san. There are a couple of slides. We can just flick through some useful references that people can chase down afterwards. But thank you for that very comprehensive coverage of the issue. Our next speaker will be speaking in French. So if you need the translation, make sure that you've selected the English channel. And I'm going to ask Padma to assist me here, but our next speaker is Naoufel Amira, who's president of the Union of Pharmacists in Tunisia, and he will be bringing us a North African view of pharmacists in self-care, especially in the era of COVID-19. Merci, Naoufel.
Thank you, Naoufel. Hello, everybody. I am very happy to be amongst you in this webinar. As you all know, the pharmacies in Tunisia are very regulated. Last March, we had the first COVID-19 case in Tunisia on the 5th of March, and a week later, we had the new government regulations, and the pharmacists have been surprised to see restrictive measures in terms of moving and traveling. So a period of time to adapt was needed. And then the professional structures adapted and thought about measures in order to protect the pharmacists, people who work with them, to protect their patients and to protect the population. Next slide, please.
Tunisia de la population du continent africain et malheureusement, on a eu beaucoup de morts grâce au Covid-19 pendant les 17 premiers mois de la pandémie. Surtout, courant cet été, on a eu le variant Delta qui a fait des ravages en Tunisie. Et ça, c'est dû essentiellement aux mesures non restrictives au niveau des frontières tunisiennes, surtout côté Libye, dont on ne connaît rien du tout par rapport au nombre de cas ou bien aux variants qui circulent là-bas. Donc, slide suivant. Prochain slide, s'il vous plaît. Donc, jusqu'à la date du début juillet.
Up until early July, the total number of tests carried out was 1,950,000 tests. The total number of positive cases, 500,000. Total number of people who convalescent, 400,000 tests. Number of positive tests, almost 35%, very high. And up until early July, we had almost 16,500 people who died, which is quite high in terms of the Tunisia population and on the African continent as well, knowing that Tunisia has a very performing health care system in general. And unfortunately, during this pandemic, we discovered that the Tunisian healthcare system was not up to the level of the expectation, and that since the 1980s, there has been a decline in terms of the budget allocated for the public health, which led to the fact that public hospitals were not able to welcome the population during this pandemic. Next slide, please. We're going to talk about the first phase that lasted almost 3 months in Tunisia. It was a general confinement, a general lockdown with total stoppage of economic and social activity and a closure of the borders. All the borders were closed since the end of March and reopened on June 24th. So we had 0 cases in Tunisia by the end of June. And since the month of May, we almost had no case whatsoever in Tunisia. Unfortunately, after the 24th of June, with border reopening with Europe especially, this led especially to the fact that we were not smart enough to implement measures, screening measures at the airport or other border points. And the pandemic increased again in September. And we had a very difficult winter in Tunisia in terms of the pandemic. First phase, measures and restrictive actions. And we can skip quickly over and move on to the next slide, please. We'll talk about the pharmacist's roles during the first phase. We were first shocked by this pandemic that we knew nothing about. And Tunisia, North Africa is very close to Europe, and very quickly COVID-19 reached the Tunisian shores, and the trade union of Tunisian pharmacists made measures, and we could not take any time off. We adapted the dosage of certain medicine and ensured that we have it in the central pharmacy. In Tunisia, it is the only one that imports medic drugs because the Public Health Ministry, the Ministry of Health, regulates this. And in March, the only body enabled to treat, the only drugs to treat was hydroxychloroquine and plecanine, and the trade union also reached out to all the pharmacists in terms of distancing measures, wearing of masks, and together with the Ministry of Health, we had a campaign to raise awareness with the Tunisian population to counter this pandemic that turned out to be very dangerous. Next slide, please. In Tunisia, as you know, there's one specificity. We have 2 types of pharmacies. Category A pharmacy that work during the day from 8:30 in the morning until 19:30 in the afternoon, in the evening. And we're very proud to have a Category B pharmacy that work 365 days a year, and they only work during the night. So with the curfew, this category could almost not work any longer. So we had to adapt the opening hours with the lockdown. And in Tunisia, the lockdown was from 5 a.m. until 5 p.m. And The pharmacists who work in the category B, for them, from a financial point of view, the situation was very difficult, and we adapted the opening hours of these pharmacies so that they can ensure the financial livelihood of all pharmacies from any category. And in every pharmacy, we had protective barriers for the pharmacist and the personnel, and to also protect the people who are ill. We also set up barriers in all the pharmacies. These were the recommendations from the trade union and the order of the pharmacies. These were mandatory measures that were implemented. They were protective measures for the pharmacists, and it was forbidden to come into pharmacies without any mask because we didn't know very well how we get contaminated by COVID-19. The order of the Tunisian pharmacist demanded that all the pharmacists are present since the end of March, and no vacation, no holiday was granted, which was very courageous for the public health. From the end of March onwards, the pharmacists have not taken any time off, category A or category B, so day and night. Next slide, please. During this time with the Ministry of Health, we had some decrees in terms of dispensing certain products, especially like hydroxychloroquine that wasn't listed, and the strategic stock does not exceed 30,000 boxes from March, April, May. So we chose to list it and to restrict the prescription to always keep a strategic stock. As I said, the stock was 30,000 boxes, and they were only delivered to COVID-19 patients during March to June 2020, which helped to appease somewhat the population and to have the necessary quantities, knowing that pharmaceutical labs in Europe stopped exporting certain products because they had specific needs in their own countries. Furthermore, on the 29th of April 2020, a law decree, an exceptional law decree, was for dispensing and renewing medication during the time when we were in lockdown. As you may know, in Tunisia, we had a very difficult first time with the general lockdown, and the order of the doctors published a press release as they feared that the general practice closed during the general lockdown. So they kept it closed during the first 3 months. And there were only pharmacists who worked in private during the first 3 months of the pandemic. So you could see how important the pharmacist is in the Tunisian health system that is especially based on pharmacists. We also had the courage, and I insist on saying the courage, we had the courage not to have the possibility to close during the first 3 months of the pandemic. It was a very brave decision from the order of the Tunisian pharmacists. Unfortunately, the other HCWs didn't follow suit, but we stayed on our own for the first 3 months. And we needed to ease the legal provisions with the measures for renewal drugs and dispensing without a prescription, with an automatic renewal for all the listed products, A, B, and C products. For list B products, there were easing measures and no renewal, just easing measures. What's more, in Tunisia, the first Institute for Accreditation of Health came with guides to take in charge COVID-19 patients, setting up hospitals and pharmacies, hospitals, smaller regional hospitals in the various conscriptions, and the first measures to take COVID-19 patients. We're talking about paracetamol, hydroxychloroquine, and also some molecules that were essential and that later didn't turn out to be that important, that necessary. Next slide, please. The Ministry of Health asked to the pharmacists to distribute masks from the 4th May onward. We had a partial reopening after a general lockdown that was very difficult for the population in any regards. And on May 4th, the Ministry of Health demanded that pharmacists distribute masks to ensure the first measure for reopening, partial reopening after the lockdown. And this was a measure that enabled the pharmacists to have the trust of the state in terms of the measures for partial reopening. And the only possibility was to have the pharmacists working together to help opening up.
Psychological support. It was a very difficult experience, including for the pharmacists themselves. The lockdown had been hard on everyone during the period. Next slide, please. This brings us to the second phase, which was managing the second spike, so from July to the end of 2020. Next slide, please. There were two peaks that were observed when borders were opened at the end of June 2020. And this meant that the variants started to arrive in Tunisia, especially with Tunisian expats who live abroad who came home. That was a real spike in case numbers. And then it was in July 2020, we started to have a lot of positive cases in Tunisia, and unfortunately a big spike in October 2020 of the Chinese variant. And in January 2021, we also had a resurgence of the pandemic. This was the British variant this time. It was very damaging, and the care was not particularly good during this period. There was a lack of beds, of ICU beds, of healthcare professionals, and a lot of people ended up dying in Tunisia during this period, and a lot of post-COVID patients who were very difficult to care for, and a lot of psychological damage in the population, and a lot of economic damage in the country as well. Pharmacists were no longer able to manage the uptick in cases. So patients needed to be cared for in clinics and in hospitals. And unfortunately, as we've already said, the public sector in Tunisia was not able to absorb the increase in number of cases. There were so many positive cases with acute symptoms that hospitals were unable to cope. For private sector pharmacists, things were changed during the pandemic. We did start to see specific treatment plans for moderate, unacute COVID-19 cases appear in pharmacies. These are cases that did not require a visit to a hospital and did not require being sent to a clinic or into the public system. And in this case, the local pharmacists were able to play a major role in caring for these moderate COVID-19 patients, especially in some of the poorest regions. We worked with the ministry to also specifically manage inventory of COVID-19 medication. The system adapted based on the needs in the country and of the people. And we were able to make some of the main drugs required for treatment of COVID-19. Next slide, please. The third phase brings us to vaccination. We started to hear about vaccination in Tunisia around February 2020. There was a national vaccination committee that was set up, and they met in June. And from then on, we started to see analysis of COVID-19 vaccines. And we decided to participate in the COVAX plan and also the African initiative for the purchase of 8 million vaccine doses. Unfortunately, the results of this initiative were not good because to date, remembering that it is September 2021 and the COVAX initiative has not been able to deliver the required number of doses to Tunisia. The African initiative, however, was quite successful in handing out vaccines in Tunisia. Since last summer, we have already received some 200,000 doses of the Johnson & Johnson vaccine. So that is for Tunisia and directly through that program. Next slide, please. In Tunisia, we decided to apply a new protocol that Tunisia didn't necessarily know very well yet. We decided to abandon local vaccination centers and create stadiums, mass vaccination sites called vaccinodromes. It's very similar to in the more developed world. And up until now, vaccinations would have been given out in local vaccination centers, and we had a good network of them around the country. We had more than 3,000 of these base health centers, but I don't know why the Tunisian government decided to set up vaccinodromes in some of the more populated areas. And this unfortunately led us to not have the right vaccination numbers that we wanted. We also have a platform so that you can sign up to get a vaccine. It's called evax.tn. And in Tunisia, in February, we decided to not get the private sector and the pharmacists involved in the vaccination campaign. This was a choice made for a series of reasons, but the state in Tunisia stated that only public sector pharmacists should be part of the vaccination campaign, and the state would be alone in managing the campaign itself. Our role was simply to sign people up on the platform. We did a lot of work working with people, especially people who are 50 years or older, to encourage them to sign up onto the vaccination platform, evax.tn, and we got excellent results. When private sector pharmacists joined the program to sign people up, there was an uptick by 15% of people signing up. Next slide, please. Okay, so in April 2021, the state observed that using the centralized vaccination system and only through the public sector was a wrong decision. At that point, the ministry called up the Union of Private Sector Pharmacists to look at how they could broaden the testing system and also look at how they could allow the pharmacists to vaccinate people in the pharmacies. A decree was issued in May, and that established a platform for statement of the positive and the negative tests. And this was the first time in Tunisia that we handed out official documents from the private sector that was also good for travel. And now the private sector pharmacists could do the tests, and the private sector pharmacists could also provide travel documents for the citizens who had received a test. These documents would have QR codes that would be recognized by all airports and all around Tunisia. We also set up technical committees so that we could organize a centralized platform that would handle vaccinations in pharmacies. This was a separate platform from the one that was set up for the private sector. And this is work that was done in 2 months and led to an amazingly efficient platform for vaccinating people. Next slide, please. Moving on to the fourth phase. This is the phase during which borders were opened with our Libyan friends. April was a very political month in Tunisia, with the difficult transition of power of the president and the prime minister. This led to some dangerous political choices, such as opening up borders without any healthcare restrictions and without any testing at the border. This led to the arrival of the Delta variant in Tunisia through Libya. And in turn, the Delta variant was very damaging in Tunisia. July was very difficult. A lot of people suffered in Tunisia. So during month 6 and 7, 2021, we saw a lot of casualties in Tunisia and a catastrophic situation in Tunisia with regards to the pandemic. The vaccination campaign with the general public was not very effective, and we had a highly contagious variant that arrived with clinical symptoms that were extremely dangerous. And that led to more than 6,000 deaths in Tunisia in 60 days. Next slide, please. Pharmacists during this Delta spike were mainly working on testing. This was done through the TROD platform, and pharmacists played a vital role during this period, this very difficult period. Pharmacists are the best local network with citizens, and this meant that we could multiply 20-fold the number of day tests versus the public institutions. And this enabled true assessment of the state of the pandemic. And it showed that the understanding at the time was quite far from what the reality was. The pharmacists getting involved enabled ministries to see the reality of the pandemic situation in the field, and this then led to fair decisions and important decisions that ended up protecting people against this Delta variant spike. and to fight against the huge increase in the number of cases. We even had some oxygen supply issues. Some people ended up dying because of the lack of access to oxygen. The success of the testing campaign also served to accelerate the setup of the first vaccination centers in pharmacies. That's the next slide. Okay, so now we're moving on to the new measures and outlook. By new measures, we mean vaccinating in pharmacies. The age bracket that was vaccinated in pharmacies was the 40+ bracket. The 40+ age bracket in Tunisia is the subpopulation that was the most affected by hospital stays and the people who needed the most oxygen. It's the age bracket that is the largest in Tunisia, and they were vaccinated using AstraZeneca. We did all of this for free for the Tunisian state, and we worked with wholesalers to set up vaccination in 1,000 pharmacies. It was a huge amount of work with all of the required logistics.
Pardon, Phil. Can I ask you just to wrap up fairly quickly because we are running out of time. Thank you.
D'accord.
Okay, merci.
D'accord. Donc, maintenant en Tunisie, on peut conclure que...
So now in Tunisia, by way of conclusion, the pandemic situation has greatly improved thanks to the input of pharmacies working to test and vaccinate. We now have more than 30,000 people vaccinated over a month, and that was just in the private pharmacies. We continue to test in pharmacies. Care for the sick continues, and the delisting and renewal of some prescriptions are still being done. Thank you very much, and I was very happy to be here with you today. I hope that we will be able to do this again soon.
Merci, Naufel. That was really a wonderful explanation of a very complex situation in your part of the world. So I'm going to ask our last two speakers who are going to give us a little bit on the regulatory perspectives to keep it really tight and perhaps even chop down a minute or so in their presentations so that we have a few minutes just to share some questions at the end, and we'll probably go about 10 minutes over time. So our next speaker is Dr. Louis Machogu, who's president of the Pharmaceutical Society of Kenya. And Louis, I know you've only got one slide, so perhaps you can just make this one a brief input. Thanks very much.
Thanks, Andy. Thanks, everyone. Good morning, good afternoon, and yeah, really nice to be here. Very insightful, very nice seeing what everyone is doing around the world and around Africa. And as you may have heard from Kenya, Dr. Daniela just shared earlier. So I'll just keep it simple. I have one slide. Next slide, please. So I'll give the regulator's perspective. We engage with the regulator. We get to sit at the regulator, the regulatory board of the Pharmaceutical Society of Kenya, as the Pharmaceutical Society of Kenya, and we provide input that's then, from the policy element and what the users are saying and how to link that up. So one of the things that we really drive is just as the regulator. What we see as the role is the regulator has to grant self-care products market authorization, because these are actually poisons, even if they've been tweaked, like what we've seen in Kenya, what we have with subcutaneous FP commodities. We are seeing that, yes, even if they've changed, they need to still be given market authorization. We're also seeing that there's need for enforcement of reporting of the expanded points of care. Is my video not visible? Someone is saying my video is not visible. Let me just come. Is it visible now? I can't see the, let me see the view I could do that would tell me. Yeah, I think it's
yes, we can see you perfectly.
All right. Thanks. All right. Yeah. So, you know, enforcement of reporting, we are seeing even companies coming up with hospital management information systems to be able to just ensure that it's integrated within that whole cycle of offering your services to the patients. Yeah. Even giving them, you know, support post once they leave your pharmacy. Ensuring that pharmacists are trained both at pre-service and in-service. We've been doing curriculum review in the country across our 7 schools of pharmacy. We are trying to see how this can be, you know, these new realities and any emerging cases can be captured into the curriculum as we move forward. Stringent regulation of the markets to ensure no quackery in pharmacy, because one of the things that will really take us back is the issue of quacks. Quacks is just someone who claims to be a pharmacist and is not, who claims to have a license and is not, and you know that can provide a lot of misinformation and abuse, and just take us backwards. And you know, and what will happen is the regulator may just even put more punitive measures, try to solve that issue. But if we are preemptive, we are seeing working with the regulator, trying to weed off the quacks, and even how the public can identify the right professional. Yeah. Sensitization of the public about self-reporting is very important so that we can be able to catch the adverse reactions as they emerge, for them not just to go there and keep quiet. The Constitution of Kenya is quite progressive in terms of consumer rights. As we are talking about collaborative practice, you know, as we're talking about, you know, patients getting to be empowered, the pharmacy also, the pharmacist getting empowered to do some of these services. We are saying, as the Constitution of Kenya, every patient has a right to access to health and information, yeah, of the highest possible standard. So where you are, how are you complying? And also, are you getting, you know, any professional indemnity cover? Because, you know, anything could go wrong. So we want to also encourage our members to also look at that, even as we are providing it as a provision from the regulator's perspective. So then in conclusion, mine is just to ask a question to all of you. How are you guys exploring in your own countries to influence policy and regulation that promotes self-care? So thanks, Andy. That's it for me.
Thanks very much, Louis. That was wonderful. So our last speaker today is Marit Ekstien. Dr. Marit Ekstien is Manager of Professional Development and Support at the Pharmaceutical Society of South Africa. So not a regulator, but she's going to focus on regulatory compliance from a pharmacist perspective as well. Thank you, Marit.
Good afternoon, Andy, and good afternoon, everybody. And thank you so much for the opportunity to be with all of you today and to also share a perspective on how we can mitigate this risk associated with self-care. Next slide, please. So I think it's been mentioned throughout by several speakers today what the aim is with self-care and where we are going to. It's to increase access, it's to have more flexible regulations related to self-medication. It's to adopt or include digital tools, but most importantly, it's to empower patients. Next slide. So how do we do it? And I think our previous speakers have mentioned it very well, is that the healthcare professional will remain present in the patient's self-care arena, and that you have to continue to have an ethical obligation towards the patient. Therefore, as a professional association like the Pharmaceutical Society of South Africa, it's very important to promote adherence and compliance with existing legislation and regulations in support of the global movement and support towards patient empowerment and self-care. So on the next slide, I've decided to use an example just to put this into perspective, where we as a professional association needs to advocate and inform our members of the ethical and professional role. So the example that I'm using is lansoprazole, and the way it's captured in our Medicines and Related Substances Act is that it is Schedule 4, except when intended for temporary short-term relief of heartburn and hyperacidity, subject to maximum daily dose of 50 milligram and maximum treatment period of 14 days. So let's break this down. Next slide. So first of all, when we look at scheduling in South Africa, we've got up to 0 to 6 schedules. 07 medication is available in open shop, so it doesn't have to be a pharmacy. Schedule 1 and 2 can be sold by a pharmacist, pharmacist intern, or pharmacist assistant without a prescription. So that's why the Schedule 2 that I've highlighted in yellow is important. And then Schedule 3 to 6 can only be sold upon a written prescription. So in this example, lansoprazole is Schedule 4, meaning only available on prescription, but there is this exclusion that will make it over-the-counter or pharmacist-initiated therapy, as Sham has referred to. So increasing that access to a patient. But now we need to take into consideration that there's certain restrictions, such as pack size, strength, duration, and indication. Next slide, please. So the first restriction is that this access to self-medication, meaning access to the Schedule 2, comes with a limitation in terms of indication, meaning this is only for short-term relief of heartburn and hyperacidity. So meaning this is not a chronic exception to the rule. This is not intended for any other indication that you might need or want to use lansoprazole for. Next slide. Secondly, in terms of the strength, there's also a restriction. Lansoprazole comes in both a 15 and a 30 milligram, but this is only applicable to the 15 milligram. And then lastly, next slide, the limitation on the duration and the pack size, meaning that this is for a maximum treatment period of 14 days, meaning that there's 14 capsules in this medication if you have a 15 milligram capsule. So moving to the next slide, looking at this example, I've got a few ethical considerations for us when it comes to this opportunity or having this medication in your hand as a pharmacist and how to deal with it. So my question is, should you simply sell lansoprazole whenever it's been asked for, without asking questions, just given it because in fact there is no prescription, they need it if you're going to use this as a loophole? Secondly, should you just simply sell lansoprazole for any indication? Keeping in mind that it has been reported before where continuous use of antacid medication mask the diagnosis of something like a stomach cancer or other serious disease. Thirdly, should you simply sell 14 capsules every 14 days or every 2 weeks to the same patient? Is that then still within the expectations of the law? Should you sell more than one pack to the same patient at the same time? Should you continue to sell lansoprazole to the same patient for an extended period of time, meaning this now turning into 6 or 12 months? And could you sell 7 30 milligram tablets or capsules? And would that be considered the same as 14, 15 milligrams? Like, is there a reason for that 15 milligram versus the 30 milligram?
Une raison à ces 15 mg par rapport aux 30 mg.
When it comes to self-care and self-medication, next slide, please. It is important to keep in mind as a healthcare professional how you mitigate the risk, including medico-legal claims. Because at the end of the day, you've made it a professional decision when you treated a patient, even if it was self-care, even if it was medication that the patient had access to without a prescription. How do you avoid self-harm? Because the patient asking for medication doesn't make him the healthcare expert. They simply ask it because they read about it in a magazine or they heard about it at a tea party. How do we ensure patient safety? And most importantly, how do we continue, even in a self-care environment, to advocate for responsible medicine use? So Andy and colleagues, thank you very much for the opportunity to share this perspective with you. Thank you.
Thank you, Marit, and thank you everyone for your contributions. And thank you especially to the last two that I had to push rather fast. So I'm going to try to share a couple of questions before I wrap up. I know that we're already a few minutes over time, but hopefully people can stay for another 7 minutes or so. So we'll continue until 15:15. But I want to throw a question to not only our pharmacists, but also to Dr. McKay. One of the challenges during COVID-19 has been sticking to evidence-based medicine. The evidence in the beginning wasn't there. It's been growing with time, but we've learned that certain products that we used in the beginning are not effective and shouldn't be used. Hydroxychloroquine is one of those examples. And we now know what should be used. So I'd ask any of you whether you'd like to comment on the challenge you felt as either pharmacists or doctors in applying evidence-based medicine during COVID-19, especially when it comes to self-care medication. So anyone like to stick their hands up? Marit?
Thank you very much, Andy. And thank you for that really valid question. And I think if we had more time, I think a lot of us would have wanted to include a discussion on that in our presentations. But I think for me, it was really sad to see how easily a patient or the public could be persuaded by non-evidence-based or non-scientific literature on what to use during something like a pandemic. And I think our healthcare workers were just so overwhelmed with all these different questions and how to manage it and how to handle it. And I think at some point, professional fatigue also set in. But it was really sad to see how easily patients and the public could just jump at whatever is the new flavor of the month. Without thinking about consideration. And I think in South Africa, we still see it with certain medications. And it's sad because I'm scared that patients made decisions without being informed. And whenever consequences come their way, I'm scared that they are going to try and shift that responsibility for that error to a healthcare professional who they at the time maybe didn't consult as thoroughly as they had. Or as they should have.
Thanks, Marit. Marlon?
Yeah, so in my experience with the first 3 waves, I think the pharmacists in my area were they provided sort of a COVID pack that patients could get just until if they had a mild illness or until they deteriorated. And I was quite happy with what was in there. It was according to the latest guidelines for that time. Obviously, our biggest challenge was the patients who had taken ivermectin, unfortunately, who again did not always do well and landed up in hospital. But I must say, by and large, the collaboration and communication with our pharmacists in my area was very, very good in terms of management.
Thanks very much, Marlon. Sham, I saw your hand as well.
Yeah, thanks, Andy. So we were clever enough in our area to set up a WhatsApp group on COVID. Almost immediately that we had the first case, and included there we had a local pulmonologist, the GPs network, the pharmacies, and we included the head of the hospital, which is in the area, Wentworth Hospital. So we had a really nice team to bounce ideas off and provide the evidence base for treatment, and that's what we used the proper guidelines. Thanks.
Thanks very much, Sham. There was a question that I said I'd come back to you with that was posed earlier when you spoke. And the question said, with such a rapid increase in demand for pharmacist first care in such a short period, what were the biggest challenges within pharmacies to adequately meet that demand? Perhaps you can give us some sense and then we'll bounce it elsewhere in Africa as well.
Yeah, thanks for that, Andy. I think it's a really good question. So maybe there's 2 aspects of it. So during the COVID care issue and the vaccine program, the big thing for us was to provide the necessary guidelines. So pharmacy associations play a key role in that. As soon as something happens, or before it happens, you start to provide the necessary guidelines so that everyone is on the same page, we're using the same tools, and we put in consistent measures into place so that you can look at what the outcomes we achieved. The second issue is that when you start to expand services like this around self-care and other areas, there is this complex relationship between healthcare providers in an area, the physician, the pharmacist, and other healthcare providers. So there needs to be that really good strengthening of that system so that you don't create uncertainty and threats to each other. The third, I think, would be the fact that you need a regulator and government that is key to participating in this advancement. So I'll give you a good example. When we needed to deliver vaccines in South Africa, it's a Schedule 4, so it's outside the scope of what a pharmacist can do, but our regulator immediately issued a Section 22A15 and allowed pharmacists to handle the vaccines, and therefore we became the big vaccine supplier in the country. And I think the third part of the model would be to ensure that a payment system is worked out, because you cannot do everything for free. Those probably are the key components that need to be looked at.
Thanks very much. Daniela, I'm going to ask either you or Louis. There was a question raised around substandard and falsified medicines. And obviously those are a risk whenever there's a pandemic. Could you give us some sense of how in Kenya you've addressed the SF medicine issue during the pandemic?
Yes, I can attempt that. So I think the issue of illegal medicines has always been there even before COVID. So as PSK, how we are addressing it is what we've always done. We sensitize the public through our social media platforms. We sensitize, and how we do it, because you cannot tell a fake medicine from a real medicine. You can't really tell the public, please only buy real medicines. So what we know is that there's an association with an illegal outlet with having falsified medicines or substandard medicines. So our message. Is it better now?
Sorry, Mazi, if you can just keep yourself mute, that's great. Thanks. Carry on, Daniela.
Okay. So what I'm saying is we've always sensitized the public about the need to get their products from only licensed outlets. And so because that's a proxy for getting registered products, and getting quality products. Because of course the client cannot tell between a fake product and a real product. So we've continued to sensitize the public before COVID and even after COVID. And possibly after COVID with more intensity, that they need to always, because there's mechanisms of checking whether a pharmacy is licensed or not. So we are always reminding them to use that mechanism to confirm, because when they go to an illegal outlet, then they're likely to get illegal medicines. Back to you, Andy.
Thanks very much, Daniela. I know that we are running 16 minutes behind time, but I want to give Jocelyn just 2 minutes to make some closing remarks from the African Pharmaceutical Forum before I wrap up. Jocelyn, some last thoughts from your side.
Thank you, Andy. I just want to appreciate all the presenters, because we are looking at the perspective in terms of how pharmacists can make a change in terms of practice. My appeal on behalf of FIP and APF is for all African pharmaceutical associations to be part of the game and improve the quality of service, so that all our member countries or in the Afro region become members of FIP and APF, so that we are one FIP in reality. Thank you.
Thanks very much. So I'm going to wrap up with a couple of remarks before I hand back to Padma. Firstly, thank you to all of our speakers today, Jocelyn, Marlon, Daniela, Sham, Naufel, Louis, Mazisam, and Marit. Thank you for the effort that you put into preparing really informative and well-informed reflections on what we've learned during the COVID-19 pandemic. As you've heard in the opening remarks today, increasing self-care as an option, as a part of universal health coverage is very important to all of our health systems. But the only way that we can do that responsibly is to ensure that people have access to the right healthcare professionals, the right services, and the right information so that they can make the best use of quality medicinal products. There is a saying that we should never waste a good crisis. And one of the mantras at the moment is building back stronger. So what can we learn from the emergency steps that we've taken, the emergency provisions that we've put in, and not lose those as we go forward? What flexibilities can we make a permanent part of our healthcare system? Learning about telehealth, for example. So I think many of the presentations today have highlighted ways in which technology, communication, and sharing, collaborative practice, has enabled us to meet the needs of our patients in ways that are responsible, safe, and advance the health of the population. So thank you very much to everyone. Padma has sent me a message saying I can close this webinar. As you'll recall, there will be a shared recording of the webinar, and we will also share the PDFs of the slides that were presented today so that people can also use those and also track down the references that were provided. Thank you very much to everyone, and thank you to the Global Self-Care Federation for organizing this webinar today. Thank you, everyone, and have a good day going forward. Thanks.
Thanks, Andy.
Thank you, everyone. Goodbye.
Thank you, everyone. Goodbye. Have a great day.